when you're on. Good afternoon and welcome to the VACCELERATE webinar. VACCELERATE is a European Union Commission-funded consortium for vaccination studies. And for more information, you see the link behind me. VACCELERATE webinars consist of live presentations, and here we regularly host experts on current research topics in the field of infectious diseases and vaccinology. A few housekeeping rules in the beginning. Please note that this meeting is recorded and it will be hosted on the VACCELERATE YouTube website. We will have about 15 minutes for questions in the end. Please write your questions into the chat and you will find this at the bottom of your screen under F&A. At least this was the case for me today. It may be different on your computer depending on what type of Zoom you're using. In case there are too many questions for the time we have, I will summarize or select some questions. Please do not use your camera or microphone. Please stay muted at any time. This meeting is EACCME certified with 1 point. To get the point, fill out the questionnaire that will be provided in the chat during the meeting. The topic today is clinical trials on chronic fatigue syndrome and post-COVID syndrome. My name is Joe Schmidt and I am Strategic and Scientific Advisor to VACCELERATE, and the presentation today will be given by Professor Carmen Scheibenbogen. Good afternoon, Professor Scheibenbogen. You're on mute.
Typical mistake. Good afternoon.
Yeah. Good afternoon. I may briefly introduce you, and I want to give the message that you studied medicine in Bonn, in Marburg, and in Denver. You were a scientist in hemato-oncology at the University of Freiburg. You completed a residency in hemato-oncology and rheumatology at the University of Heidelberg. And from 1998 to 2007, Professor Scheibenbogen was attending physician at the Charité hospital in Berlin, leading the working group on tumor immunology. In 2007, she became a full professor and director of the Institute for Medical Immunology at the Charité. And since 2018, she has been the director of the Charité Fatigue Center. In 2021, Professor Scheibenbogen was one of the co-founders of the Post-COVID Network. And I think it is wonderful that you can give us your insights into the current topic. And it is my great honor and pleasure to be able to ask you now to give your presentation. Thank you very much for being here today and for presenting your data.
Yeah, and thank you very much for the kind introduction. And it's an honor for me as well that you're interested in my research and to share the data with you. I share my desktop now. I have prepared some slides. You heard already about my background, and I'm going to talk now about our approach for clinical trials on ME, CFS, and post-COVID syndrome. And before I come to the clinical trials, I give you a brief overview about the clinical spectrum of these diseases, and then come to current treatment options, which are mostly symptomatic so far, and then our approach to develop clinical trials based on the known pathomechanisms. And that's what we have known in 2020, that after COVID infection, we have a subgroup of patients who have persistent symptoms, and these are actually many symptoms in various combinations. One of the most frequent is fatigue and cognitive impairment, and exertion intolerance, another one. Many of these symptoms we know already from other post-infectious diseases. And now in 2023, we have learned a lot about long or post-COVID as well. The WHO definition, I think, is a useful working definition, having ongoing symptoms for more than 3 months and being relevantly impaired in daily life. And what we know is that COVID can trigger many different diseases. This includes many diseases we have known already before COVID. So typical diseases are cardiovascular, pulmonary diseases, autoimmune diseases, psychiatric or psychosomatic diseases, and the majority of the younger patients, however, has diseases which are more or less specific to COVID or to post-infectious syndrome. So we know that a subgroup suffers from severe neurocognitive post-COVID syndrome, and we have learned that virus persistence plays a role, but also antibodies, autoantibodies, and inflammation. And then we have this large group of post-COVID syndromes with various symptoms, and we know already from the post-infectious diseases. We have seen in our clinic that a subgroup of these patients has the ME CFS disease, which can be defined according to the so-called Canadian consensus criteria, but we do have different criteria here, which only partly overlap. And we'll comment on this again. And we have another group of patients who suffer primarily from cardiovascular dysregulation. POTS is among these, and orthostatic hypotonia. And the disease chronic fatigue syndrome, or myalgic encephalomyelitis as abbreviation internationally, the term ME/CFS is now used, has been known already for decades. It can be triggered by various infections. Among those, EBV is well known, enteroviruses, influenza, and the key problem of this disease is not the fatigue, but it's the exertion intolerance. And that means that often minor daily activities leads to an aggravation of all symptoms, which is called post-exertion malaise, and that can be quite severe. And patients do always suffer from neurocognitive impairment called brain fog. They have pain, they have sleep disturbance, orthostatic intolerance is quite frequent, and typical is an hypersensitivity to noise, but also to light or certain smells. You can clinically find several abnormalities in these patients. So the fatigue is typically a muscle fatigue as well. You can measure by hand grip strength. You can find orthostatic dysregulation by just measuring blood pressure and heart rate upon standing. And patients often have problems in endothelial function, which you can assess also by various measures. I want to mention that there is a similar clinical disease, most likely with a different pathomechanism, which can be triggered also by diseases of the collagen structure, like Ehlers-Danlos or Marfan syndrome. But there are also patients who get sick following a physical trauma, probably related to cervical spine trauma, and psychological trauma or stresses can also trigger such a disease. According to the ECD classification, it's a neurological disease, and the prevalence is actually quite frequent. So we have now data in Germany from Krankenhausgesellschaft, and they have recorded already 350,000 cases in 2018, and now in 2021, 500,000 patients in Germany, and we estimate that numbers are continually increasing. It's a typical disease of younger females, and it's until now in most patients a chronic disease, and about 50% or more of the patients are so sick that they are unable to work. The most severely disabled are bedbound and some are so sick that they need full-time care and help even with feeding. And this is an example or a report from one of these patients who often have no good support structure. We initiated in 2020 an observational study. The first patients contacted us with fatigue and other symptoms, and we wanted to see if a subset of these patients do indeed fulfill the clinical criteria for ME/CFS. And the first paper on this study you see here. We have now follow-up data which are available as preprint in meta-archives. And to sum up, the most important findings is that looking for this PCS subgroup with moderate to severe fatigue and exertion intolerance, which persists for 6 months, that about half of these patients do suffer from ME/CFS according to these Canadian criteria. And as we have known for a long time, this is a disease which affects more women than men. We have a median age here of 43 years. And again, more patients are unable to work, and most patients do have a chronic course, and that is depicted here by these scores. So the Bell score is a score developed to assess the functional disability in ME/CFS. 100 means healthy, 0 means bedridden, and as you see on baseline at month 6, the average Bell score for ME/CFS patient was 40. ME/CFS patients are depicted in blue, and then the other patients with post-COVID syndrome but not fulfilling the Canadian criteria were similarly sick at that time point. When we now look 2 years later, then ME/CFS patients haven't improved in contrast to the other group, and a very similar data we get when we assess the patient's physical function status by the SF-36. Having just a brief look at potential biomarkers, we found that the majority of patients do have elevated interleukin-8, which we measure in erythrocytes, which is a much more sensitive assay than just measuring circulating IL-8. And we see some decrease at follow-up 1. And we also see frequently a diminished phosphate level in serum, which is a potential metabolic marker. And here we see that again, this persists in ME/CFS patients, whereas it improves in the other patients. We also found in this study that the diminished hand grip strength at month 6 is probably a good prognostic parameter for an unfavorable prognosis. So coming to the current diagnostic and therapeutic possibilities, we have seen many biomarkers during the last 12 months, but we have no diagnostic marker yet. So diagnosis is based on clinical criteria. And so far we have for most patients only symptomatic therapy to offer, and we have few clinical trials running so far. This is an overview on the diagnostic criteria we have for ME/CFS, which is probably the most severe form of post-COVID syndrome. So if you want to use these criteria in diagnosis, have a look at on the website of the Charité Fatigue Center. I show you the link at the end. There you find the scores, and we have simpler diagnostic criteria, which are, however, less specific. The so-called IOM criteria, which require just 5 symptoms to be present. And again, you find these criteria on our website. Regarding clinical management, we have German guidelines for long post-COVID, and we do also have a living guideline from the WHO, which also has a chapter on long COVID. We also wrote several articles for practitioners how to diagnose and how to do symptomatic therapy in these patients, which you also find on the website of the Charité Fatigue Center. And we do also have a Versorgungsstudie, a care study focusing on the rehabilitation of ME/CFS patient. That is something we can offer those patients who are still able at least to be part-time active and probably stay in their jobs. And so these patients get, after being diagnosed in our clinic, rehabilitation, which is specifically tailored for these patients. So they get information about the disease, they learn how to manage the disease, specifically the pacing strategy. They got symptom-oriented therapy, and then all the problems which come along with such a severe disease in younger patients, they get support, and importantly, they get also support with their workplace, and one tries to adapt the workplace so that it's still possible for them to work at least part-time. Coming now to the topic, the specific topic of my talk, clinical trials. And clinical trials is linked to pathomechanisms, because the therapeutics we want to develop based on our knowledge on the pathomechanisms of post-COVID syndrome and ME/CFS. And in this overview, I listed the pathomechanisms which we think at the moment are most relevant in post-COVID syndrome, and there's quite an overlap with ME/CFS. We know that many patients with post-COVID syndrome do have ongoing inflammation. I showed you already the interleukin-8 data, but we have numerous studies now showing both elevated cytokines, but also activated monocytes or T cells. Then we have quite good evidence now that in a subset, SARS-CoV-2 can persist. And this is, for example, shown in lung biopsies or colon biopsies, and most recently also in bone marrow. And we have learned as well that EBV reactivation during acute COVID is also a risk factor for developing post-COVID. So one may speculate that at least in a subset, there are many similarities to ME/CFS we see following Epstein-Barr virus infection. And then looking to ME/CFS, we know in ME/CFS already that autoantibodies do play a role. So we have various types of autoantibodies. Most interesting are those against the so-called G protein-coupled receptor antibodies, against the beta-2 adrenergic receptor antibodies, which is dysregulated. So this strong adrenergic dysregulation in ME/CFS, which actually may explain numerous symptoms. We know that endothelial dysfunction plays a role, and hypoperfusion, and both mechanisms do play a role in post-COVID syndrome as well. And I want to mention this great review article by Hannah Davis and Eric Topol, which was recently published. So having a closer look to the pathomechanisms in ME/CFS, so we know that hypoperfusion is a central mechanism in the disease that has been shown for the cerebral hypoperfusion, and has also been shown for the muscles. So especially upon exertion, these patients do not adequately perfuse muscle or brain. And the reason for this often paradox vasoconstriction is most likely a dysregulation of the adrenergic stimulation of vessels. So we do know that alpha adrenergic receptors are responsible for vasoconstriction, and the beta-2 adrenergic receptor for vasodilation. And in ME/CFS patients, we see that this beta-2 adrenergic receptor is downregulated. And we also see that these patients do have antibodies which impair the function of the beta-2 adrenergic receptor. And this may explain actually well all the symptoms of this complex disease. And just want to mention that we recently performed a study performing MRI to detect natrium in these patients' muscles. And to shortcut this story, this finding provides us with further evidence that the patients do not adequately perfuse their muscles upon exertion, and that is already published. So if you're interested in the details, you'll find this paper. So now coming to our clinical trial platform, we have to admit that it's really a challenge to develop therapies in such a complex disease, which is clinically heterogeneous, but most likely also heterogeneous regarding the pathomechanism. And nevertheless, we think there is an urgent need to go forward now and do clinical trials. Patients are urgently needed. We have, I didn't mention the numbers of patients, but we know that we have a huge number of post-COVID sufferers. Something around, I think 5% are those who are really impaired and need specific treatment. And our approach to do clinical trials is to combine it with research. So we think that all patients who are treated in a clinical trial should have a comprehensive analysis of all those biomarkers I just mentioned. So we, in our platform, have now the facility to analyze all these different biomarkers, in part by omics technologies. And we also built up a diagnostic platform to study in depth the abnormalities, and we have learned to be relevant in post-COVID. So we do analysis of the vessel function, of the hypoperfusion. We do functional MRT. Actually, by functional MRT, you can see hypoperfusion in almost all post-COVID patients with fatigue symptoms. And the first trials we have started now, or are just in the process to start, those 4 listed here. I'm going to give a little bit more detail on the next slides on these trials. And we were able to build up these platforms and to perform these clinical trials by funding from the BMBF. We got end of 2020, and we will have funding till the end of 2023. And we hope, of course, that we will continue to get funding by BMBF and hopefully also find partners from the industry. So far, it's quite difficult to convince the pharmaceutical industry to go into clinical trials in post-COVID syndrome, and that has been the situation already for decades in ME/CFS, probably because the mechanisms are still not thoroughly settled, and the complexity of the disease. So we have the information regarding the structure of our clinical trial platform and the respective clinical trials on our website. And I'm going to show you now some data about the very long study. And we are just going to recruit the first patients in May. So we have approval now from the ethics committee. It took us almost 1.5 years for this really high bureaucratic efforts we have nowadays to get such a study running. And it is a drug which is already licensed for the treatment of cardiovascular diseases, and vericiguat is a stimulator of the so-called guanylate cyclase, which is the same pathway which is activated by nitrate, and it's very effective to dilate vessels in pathological conditions. So we are going to treat patients in a phase 2 double-blind placebo-controlled 2-arm study. So patients will receive either vericiguat or placebo for 10 weeks, and we do a dose escalation and 4 weeks follow-up study. And I'm not going into details, but the patients we select for these trials are those who fulfill the ME/CFS criteria following COVID according to the Canadian criteria. This requires that the post-exertional malaise lasts at least until the next day. But we do also include a group of patients who has a shorter post-exertional malaise, something we very frequently see in post-COVID patients. These patients do fulfill the so-called IOM criteria, but what we have learned during the last 2 years, looking at different biomarkers, these are definitely distinct pathomechanistic group. Therefore, we stratify for these patients. And another inclusion criteria is evidence for endothelial dysfunction or hypoperfusion. And we have here a biomarker, the endothelin-1, which is elevated in a subgroup of these patients, or we measure impaired perfusion by this technique OCT, which we analyze the perfusion in the retina. The other trial, which is already running, is the repeat immunoabsorption. This is an observational trial with a primary aim to see if immunoabsorption improves physical function in ME/CFS. So immunoabsorption is a technique by which you just wash out all immunoglobulins or antibodies from a patient. And if you have pathogenic autoantibodies causing the disease, then you usually see a rapid disease improvement. And this is for us an important information to learn if and in which patients autoantibodies do play a role. We use as primary aim the SF36 physical functions. We do one immunoabsorption, and in patients responding, we then have the possibility to do further immunoabsorptions in case patients do relapse again. And again, we include here patients with ME/CFS according to Canadian consensus criteria, because we have already data from our biomarker studies that in a subgroup of these patients, the elevated beta-2 adrenergic receptor antibodies do correlate with disease severity, especially with fatigue and Raynaud symptom. That means that patients frequently have diminished perfusion of hands and fingers. And we repeat this procedure 5 times during a period of 10 days. And actually, we do have already data from the interim analysis. So this study concept is not new. We did already small trials in the past with patients suffering from ME/CFS following other infections. And we got from these trials first data for evidence of this approach. However, we were unable to do follow-up studies because of the lack of support. So this is already data now from the ongoing trial. We used another device. It's from the company Miltenyi. In the past, we worked with the devices from Fresenius, but we see that this system works nicely as well. So after 5 immunoabsorptions, we can efficiently deplete the immunoglobulins. This shows you the level in serum before and after immunoabsorption. And we can deplete not only IgG, but also IgM and IgA. Of course, plasma cells continuously produce immunoglobulins, and therefore, after 4 weeks after the immunoabsorption, levels usually rise already quite strongly again. Now coming to the clinical results. These are the results from the first 10 patients we want to publish as a preprint, because everybody's so eagerly waiting for these results. And what we see is that according to our definition, response is defined of an at least 10-point improvement in physical function. 7 of these 10 patients had a clinical response according to this definition. So this is the SF36 value before immunoabsorption. The range is 100 means healthy, 0 means unable to do anything in daily life. And you see that after 4 weeks, we have here 3 patients with a very good response. The dashed line is the median, and we have we have 4 patients with a very good response, and another 3 patients with a moderate response. And these are same data, just in a different way of presentation. So this is for us a starting point that we want, that we are convinced that we should develop further therapies targeting autoantibodies in these patients, because immunoabsorption is a technique which we cannot offer to all patients, and which is also very strenuous for these often severely ill people. So there are numerous treatment strategies, and many of them are already licensed to treat autoantibody-mediated disease. Just to give you an overview, these are the different antibodies able to deplete memory B cells or plasmablasts, which are already licensed or which are in clinical trials for other autoimmune diseases. And we do also have another therapeutic principle by targeting Fc receptors on cells, which modulates the metabolism of immunoglobulins and also leads to a decrease of immunoglobulins. And it has been shown that this is an effective treatment as well for autoantibody-mediated disease. And the first of these drugs, efgartigimod, just got licensed in myasthenia gravis, and there's already a trial running with efgartigimod in the US in patients who have POTS syndrome by COVID triggered. And we have also discussions with this company, and we couldn't convince them so far to do a trial in ME/CFS patients. So our approach is summarized in a paper, which will, I think, appear within the next days as a preprint. You see that Oliver Connelly is co-author of this paper. And this is a table out of this paper just to give an overview of the trials which are currently running in post-COVID syndrome worldwide. And these trials focus on the mechanisms I mentioned already. So these are either targeting immunomechanisms. Then vascular targeting is actually only our VACCELERATE trial at the start at the moment. There is the approach of hyperbaric oxygen therapy, which most likely also improves perfusion. There is a trial with Paxlovid running in the US at the moment. And then there are several trials with neuromodulators, which are, however, mostly symptomatic therapy for these patients and no cure. So to summarize my data, I showed you that the clinical spectrum of post-COVID is broad. We have many symptoms. We have known diseases already, but we do have also various symptom combinations. And among these syndromes, ME/CFS is most likely the most severe form of post-COVID. and it's affecting at least 500,000 of patients already in Germany. I showed you that important pathomechanisms are inflammation, autoimmunity, hypoperfusion, and viral persistence, and all these mechanisms can be targeted by therapies, and we have already numerous therapies which are licensed in other diseases, which offer the possibility for more rapid development in post-COVID syndrome. The current situation is that we have only symptomatic therapy for most patients. Pacing is important for the majority, not only ME CFS patients, but also post-COVID patients, in whom many do suffer from exertional intolerance as well. And at the moment, we have approximately 30 randomized clinical trials worldwide in post-COVID syndrome. So this is the website I mentioned of the Charité Fatigue Center, where you find the diagnostic criteria and also the articles I mentioned. And we do also have information for patients and informations about our clinical trials on this website. And this is the website of the post-COVID network of the Charité, where you also find literature and education. I want to mention the Weidenhammer-Zübele Stiftung supporting our fatigue center, and we will have conference next month at the 11th and 12th of May, an international meeting on ME/CFS, and it's a hybrid meeting, so I can invite you all if you're interested to participate. You just need to register. You find the link also on the website of the Charité Fatigue Center, and registration is free. And we do have a symposium on the afternoon of the 12th of May, which is for the public, and we will provide information about the current situation of care and research on ME/CFS in Germany. And again, you are cordially invited to participate. This is also the International ME/CFS Day worldwide. So coming to an end, I thank you for your interest, and I'm happy to answer your questions.
Thank you very much for the great overview. I have to admit, I have been treating patients with infectious diseases for a long period of time, and those with ME/CVS cost most of my time with little outcome for the patient and for myself. It was always very, very difficult, and particularly those who had Epstein-Barr virus infection in the past. I remember from the late 1980s how difficult that was, particularly with the AIDS pandemic around, and people coming with all types of infection, and you never knew how to sort out what is what. So thanks very much for the great insight, particularly into pathogenesis. I have 5 questions by now, and the first one is, we know that PCS is often associated with a wide range of autonomic dysfunctions. Many have a genetic component. Couldn't this be used as a tool to confirm PCS on the one hand, or to determine the risks for PCS in still healthy individuals on the other side?
Yes, I fully agree. I didn't mention autonomic dysfunction because I didn't want to talk for 2 hours, but I briefly mentioned POTS, postural tachycardia syndrome, or orthostatic hypotonia, and this is a typical feature of autonomic dysregulation of the cardiovascular system. So what we see in many patients with ME/CFS, but also with PCS, is that they have a sympathetic overactivity. I mentioned the adrenergic dysregulation of the vascular perfusion. I think this is also part of the autonomic dysfunction, and you can measure clinically autonomic dysfunction. One possibility is to measure the regulation of the cardiovascular system by doing such a Shellong test, or the modified Shellong test is a Nasalin test. but you have also other possibilities. We have, for example, a questionnaire, the COMPASS questionnaire, developed by the Mayo Clinic, which actually asks for 6 subdomains of autonomic function. You can measure heart rate variability. And regarding the suitability, I think it's an important diagnostic criterion, yes. Regarding genetic variations, we know that there are some variations, for example, in the adrenergic receptors, which are associated with these diseases. We do also know that, for example, in POTS also autoantibodies to adrenergic receptors do play a role, but so far we have no good diagnostic test which fits for the majority of patients. Again, these biomarkers are only elevated in a subgroup, and as usual we have an overlap with healthy people, so it's not a good diagnostic test yet.
And a second question from Dr. Holler is, are persistent viruses also detected in those who have fully recovered from the disease?
Coronaviruses?
I guess any.
Yeah. Well, actually, there was a very interesting study published a few weeks ago, and they analyzed patients who died from accidents. And I guess that many of these patients were recovered because they were just an average of patients who had bad luck. And they showed that in these patients, approximately 1/3 of the patients had evidence of persistent coronavirus infection, especially in the bone marrow of the skulls. So I guess also virus persistence per se is not the answer for the post-COVID syndrome, and is probably not a good diagnostic marker. But that is speculative. So we have no good data yet because it's so difficult to measure viral persistence. So you do not pick up the virus in the pharynx anymore. So you need very sensitive assays. There is a platform called Simoa, which is much more sensitive than ELISA's, but it's not that easy to get this technique. We are working on this in our platform. Or you need to do biopsies, though there's many post-mortem studies with lung biopsies performed. There's a study also on colon biopsies showing virus.
So yes, there are viruses still out there, but probably not in all patients, right?
Yeah.
It's probably in some.
Yeah, we do not know yet, yeah, but I guess that's the truth.
Another question is, the new EU regulation on clinical trials and its system, CTIS, were designed to improve and facilitate the authorization of procedures for clinical trials and their monitoring. Was the very long trial submitted via the new regulation or the old one? There was no
very long was still submitted with the old regulation, but I don't want to disappoint you, but CETIS doesn't really make our life easier because, well, they are faster. We have one trial now submitted to CETIS, but they require even more forms. So that's not really that it's getting easier to do clinical trials. Oliver Connelly may know more about this and may add probably some information, but
Oliver, you want to chime in?
Agree. So so far we avoided to submit, but now we have several that we need to submit under CETIS. So anyway, we will learn to live with it, right?
Yeah, usually life doesn't get easier with new options. But anyway,
especially not nowadays.
One other question is, how did you control for the immunoabsorption study? What was the control group? I mean, it is possible that the natural course of the disease results in an improvement anyway. So did you have any controls that were not treated, or was this a feasibility to begin with?
You mean the immunoabsorption trial? Well,
yeah.
This was just a first trial to get evidence if removing antibodies gives us a hint of efficacy at all, because when we face such a complex disease with so many pathomechanisms, we do not know just the fact that somebody has an autoantibody is of relevant for the disease. So, of course, we will perform now follow-up studies. We will do now a sham-controlled trial within the platform. And but I read with interest the immunoabsorption trial from Jena, which was published 2 weeks ago in the Deutsche Ärzteblatt, and they used the same approach, but they did not include ME/CFS patients, but just post-COVID patients with fatigue, and they saw no response at all. So it has not such a strong placebo effect, the immunoabsorption. So that makes me even more convinced that that is therapy which has a potential in these patients. But I fully agree. We need to do follow-up studies.
Just my own question, and maybe you said it, but I was busy with reading the questions here, and I didn't get it up. Rituximab and other B-cell active biologicals, do they have any effect, or is this all at this point still experimental?
Well, difficult topic. Actually, there is a group in Norway, in Bergen, and they started rituximab trials in ME/CFS already more than 10 years ago. And the first trials they performed, these were placebo trials and other non-placebo controlled trials. They showed good efficacy in many patients, and several patients were cured. Long-lasting cures, and then they went on and performed this multi-center trial. And in this multi-center trial, this was negative. They had a 30% response in the placebo group as well. And well, one needs to speculate now why this is. Probably it's because these patients usually are not very well cared at all. So many of these have no adequate symptomatic therapy either. And it is a disease in which we do have a high placebo effect, although in other trials. And then the people had the problem that they had to lower the dose of rituximab because they didn't get sufficient support from Roche and so on. So the question if B-cell depletion is effective in ME/CFS or not is not solved yet. And
Okay.
and when we now go for B-cell depletion again, we will definitely use the more effective either CD20 antibodies. They are much more effective nowadays than rituximab to deplete B cells. Or if we get it, we would prefer a CD19 antibody, which can also deplete plasma blasts. But we will pre-select our patients based on immunoabsorption. So we will only include patients in these B-cell depletion therapy if they had a first response to immunoabsorption, which is usually not long-lasting because you only wash out the autoantibodies, but you do not get rid of the autoantibody-producing plasma cells. And long-term efficacy and cure you can only achieve when you deplete B cells or plasma cells.
Would or do you even think of a even more specific depletion therapy, like at specific receptors or specific antigens? Right now, it's, you hit it all. The question is, do you have any idea where you could be more specific?
Yeah, of course, that would be the long-term goal. But at the moment, we first of all have to provide clear evidence that B-cell depletion is effective and in which subgroup of post-COVID syndrome and ME/CFS it is effective. It will definitely not be a treatment for all of the patients. And then in other diseases, there are already strategies focusing, for example, on specific to target specific plasma cells, and that would of course be then an option for the future as well.
One other question is, do we know why there are swollen lymph nodes in ME/CFS?
Well, yes, we think that this probably has to do either with EBV reactivation, with frequent in patients who suffer from post-exertional malaise, because this goes along with immunosuppression. And the other concept is that it's probably related to an exaggerated response of muscles and to hypoperfusion, because muscles, if they do not get enough oxygen, they release a lot of mediators, pain mediators, but also bradykinin, for example. Bradykinin leads to endothelial leakage, and this may also result in lymphatic drainage and in swollen lymph nodes.
So it's a metabolic event one way or another, yeah?
Yeah. Mm-hmm.
In the case of PEM, rest is recommended. How can a patient be further supported?
Well, we have some recommendations. So if you have specific patients you take care for, write to me. I send you a leaflet, how to treat PEM. And this is based on the one hand on symptomatic treatment with benzodiazepines. So Tavor, for example, is a drug which very effectively ameliorates the symptoms. They usually have these strong hypersensitivity patients in the PEM, and by activation of GABA via benzodiazepines, you can help them quite well. Of course, this is no therapy for a longer time. Then we recommend to give patients enough fluid, so saline infusions can be helpful. Pain treatment is important. Sleep treatment is important. Patients usually cannot sleep in this situation. So we have good experience with low dose mirtazapine, which can be quite effective. And then it's also important that you get away every other stressor from these patients. So even their energy metabolism is so severely impaired that being too warm or too cold is an additional stressor. So I'm happy to provide you with our leaflet, how to manage PEM. And there is a paper from a Stanford group we just translated to German, which also focuses on this topic, how to take care of PEM and the very severely sick patients. Mm-hmm.
Maybe you can send the leaflet and the literature bibliography to Janina or me, and we will.
No, that is with specific recommendations for drug dosages. So I can only
okay,
yeah.
Okay, yeah, okay. Okay, yeah. One question is there any effect of M3, M4 autoantibodies on ME CFS?
Yeah, actually, this has been one of the research interests for us during the last years, because we think that the autonomic dysregulation may well be caused by autoantibodies against these receptors. And there has been already research from Japan more than 10 years ago showing a potential role of antibodies against muscarine acetylcholine receptor, and we did also observe that they are elevated in a subgroup of patients. And what we see, and we have seen this in several analyses we did, that we have a correlation of the levels of these M3 and M4 receptor antibodies with symptom severity. Interestingly, in post-COVID syndrome, this is only true for the subgroup fulfilling the ME/CFS criteria, but not for the other post-COVID syndrome patient. This is the reason why we do only include ME/CFS patients in our immunoabsorption trials.
Mm-hmm. Interesting. So it gets a little bit more into details here. One question is, do you use validated scores or questionnaires in your clinical practice to evaluate symptoms related to fatigue in PCS patients?
Well, we use the Gelder fatigue questionnaire. The Gelder fatigue questionnaire has the problem because it relates the symptoms to usual. So it asks the patients, are you more fatigued than usual? So it's actually not such a good questionnaire when you will use it in clinical trials for follow-up analysis. So for this, we, in addition, use the fatigue severity scale.
Mm-hmm. I see no more questions in the chat, and let me see, there is also the option to put your, this is what I said initially, there is this F&A button down at the line, but nobody asked the question to the F&A option. But anyway, I have no more questions. I'm not sure, Oliver, if you have a last word, and then we may close the session.
No, it would just be a big thank you from me. It was great to have the opportunity to discuss with you and with, well, one of the eminent experts, clearly. So it was fantastic that you took the time, because we know that your schedule is packed and you receive a lot of invitations. So thank you very much.
Yeah.
Also, thank you very much, Professor Scheibenbogen, from my side for your time. Congratulations to your excellent research and all the publications that I saw just today in this meeting. Thanks everybody for joining us. Please like and share our webinar if you see it online on YouTube, and we will see you again in the near future for our next webinar. Have a nice afternoon. Thank you very much, and bye-bye.
Bye.